No, you
Yes,
are.
ma'am.
Dekho, that
We are live now,
conference will
ma'am.
finish in 2 days, but we are the permanent friends.
Yes.
Absolutely, ma'am.
Good evening, Kiran madam.
Good evening, good evening, good evening.
When Kiran ma'am is there, take a photo. Ma'am,
Yes,
Yeah.
ma'am.
will
Yes,
leave
ma'am.
after
Sure.
some.
Okay, ma'am. We are live now, ma'am.
Good evening, everyone. A warm welcome to one and all for this 11th episode of our webinar series called AKSHARAM. AKSHARAM is our President, Oxy President Dr. Vijay's pet project, teaching project, mainly focusing on one particular topic, and A to Z of the entire topic is taught by one eminent teacher with this, the faculty, the PGs, the faculty, and the junior consultants and senior consultants, all of them can benefit from this. Today's topic is about gestational diabetes. We know there is an increase in incidence of gestational diabetes in the entire world, not only in Southeast Asian countries, but also in the entire world. And it is a very important exam question for the examiners and also from clinical point of view, because there are a lot of guidelines, a lot of studies have come up. This episode of Gestational Diabetes is presented by the Oxy Medical Education Committee along with Foxy Medical Education Committee. And I once again welcome you all for our 11th episode of Aksharam series. Next slide. We always start with lighting of the lab. Welcome address by Dr. Vijaya, President Oxy. She is the chairperson of Medical Education Committee of Oxy. Vijaya madam, we all know, is a very eminent teacher. She is a professor and HOD at ESI Medical College, KK Nagar, Chennai, former director of IOG Madras Medical College, Chennai. Madam is a dynamic president we have got, and we are all working for our Oxycon project, our annual conference now. She has a lot of special interests and awards to her credit, and a lot of publications and papers to her credit.
Hi everyone, and this is one of the main activity of the Oxy as after I took over last year. And of course, we have to learn every day. Lots of new projects and new research and new ideas keep coming. And every month I take a lot of time in selecting and choosing the best person for the best topic. That is an important exam going topic. And I also Geeta and Karpagam is always with me in Aksharam doing this series. And also Kiran ma'am, from the beginning, she has been a solid support to me. And I hope this is benefited for all the pages. And one good news is our Oxycon conference, we will compile all the lectures that has been done in the past for the past 11 months will be compiled and given to you as a CD free. So in one more is there in March, but nevertheless, all these 11 will be compiled and be given to you. So don't worry, you can give and you can refer anytime when you're going for the exam. So with that, I just ask Geeta to proceed with the other usual things.
We always start with the lighting of the Kuttuvalakku, our lamp, our tradition. And next, our invocation to Goddess Saraswati. with the divine blessings of Goddess Saraswati, now I introduce our Secretary of Oxy, Dr. Geeta Lakshmi. She's an associate professor at Government RSRM Medical College and Hospital, which belongs to Stanley Medical College, undergraduate and postgraduate teacher for many, many years, secretary at Oxy, our very dynamic and vibrant secretary. And she has a lot of areas of interest of high-risk pregnancy, adolescent health programs, and medical education, and a lot of papers and posters to publications to her credit. Madam will be rendering the Oxy prayer. Next.
Thank you, Garpagam. So with the blessings of the Almighty, we shall start the 11th episode of Aksharam on gestational diabetes mellitus. Thank you, God. In humility we gather. In gratitude we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and mom reborn, the courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you.
Gestation diabetes mellitus 65 months, carbohydrate intolerance of gestation diabetes mellitus 65 months, carbohydrate intolerance of varying.
Okay.
Were you able to hear, Ma?
Yes, you're able to hear.
Yes, because somebody's voice was there. That's it.
Yeah, can we welcome
Ma'am, you can skip the introduction because
Yeah, madam, please.
Kiran ma'am, you are always with Oxy and we continue to be together, and because you are an inspiring source for me to start this medical education committee, and we will do much more in future. And you all know Kiran ma'am is now conducting the national conference of menopause, Indian Menopausal Society at Kanpur. She's very busy amidst a busy schedule. She just agreed to be there for 5 minutes. Ma'am, Kiran ma'am, over to you, ma'am.
thank you so much, Dr. Vijaya. And it was your love and your insistence that I joined today, because I was actually not it was not possible for me to join. You just can see I'm in a car only. I'm just coming back and I need only 15-20 minutes to change and go back. So it was your love and affection which has made me that I will join. It's a really wonderful friendship, I would say, and the collaboration for the benefit of medical fraternity, that we are conducting these programs of under the banner of Oxy Medical Education Committee and Oxy Medical Education Committee. Dr. Vijaya is a very good person. That is, hardcore academician. She is always selecting those topics which are important for postgraduates. And everyone knows diabetes, which is almost like an epidemic. It is increasing.
You're muted. Madam, you're muted. Unmute, Kiran ma'am.
Just got muted, or I was muted since very beginning.
Now only.
Just now.
Few seconds.
Okay, so the diabetes we all know is a silent epidemic, and which is affecting because of probably the lifestyle, the factors and many factors. And she always, Dr. Vijaya tracks out the gems of the persons she finds from all over the India and selects them. So I'm sure all the postgraduates will be benefited. And this is a good idea which I just heard, that all the topics will be compiled and given to the postgraduates for their examination purpose. Please send me one copy also. I am also a student. Even now I am a student.
Thank you.
So, it's very wonderful. Please go ahead. My warm well wishes are with you. And I'll always be with you as far as possible. Love you.
Always
Love
there.
you
Thank
so
you.
much.
Thank
All
you.
the best. All the
Thank you
best.
so much.
Thank you.
Thank you so much, madam.
Thank you.
Thank you, ma'am. Thank you.
Karpa, you have to come for inauguration also.
I will, madam. Next,
Okay.
thank you so much, madam. Next, we'll start her teaching session. by Dr. B. Sushila Rani. Vijaya madam, please go ahead and introduce the speaker, madam. Teacher.
Sushila Rani, everybody knows about madam, and almost all the conferences madam will be there, and either as a chairperson or a speaker or expert consultant. And she is a medical director and consultant of Manjushri Specialty Hospital, and she's a postgraduate teacher, past president of BSOG, chapter secretary of IMS, and chairperson of BSOG Postgraduate Forum. Very important. Up to 2021, she was there, and winner of the Vidya Basin Award and the Best Teacher Award. Who else can talk about GDM other than Sushila ma'am? And Sushila, over to you.
Thank you, Dr. Vijaya, for your kind words. I hope to do justice to the topic. What happens is when a teacher is over enthusiastic, she's likely to go beyond the time. And quite often these days, the teachers are more enthusiastic than the students. So please do remind me when my time is over. And if there is anything that you feel can be cut short, you can tell me straight away if it is not likely to be of use to the postgraduates. Okay. So I start my session. Thank you all for giving me this opportunity because this is one of my very favorite topics. And I owe it to you.
Thank you, ma'am.
Right. Right. Gestational diabetes. Okay. Hyperglycemia in pregnancy is one of the most common medical conditions that women encounter. This statistics 1 in 6 was quite some time back, which was presented at FIGO. But I think what we see in our day-to-day practice is almost 1 in 3 pregnancies are found to be diabetic. But the best part is 84% of these are due to GDM. Now, I'll draw a distinction between GDM and pre-gestational diabetes, etc., during the course of my talk. What I would like to highlight here is that 199 million women have diabetes and 313 million by 2040. Now, this million, trillion, and all these numbers don't make an impact at all because when you hear people suffering or when there is this numerical terms to describe the enormity of the situation don't seem to make an impact at all. So what I thought, I will tell you the story of Mala. Mala's mother was diabetic at the age of around 40 and she had 3 children, of which Mala was one among them. And by the time Mala got married and she produced 2 big children, her mother's diabetic condition deteriorated to such an extent that she needed dialysis. Now, soon her Mala's 2 brothers also followed. And by the time they reached the age of 30, all 3 siblings were found to be diabetic. Now, this condition is something that is likely to perpetuate to such an extent that the subsequent generations become diabetic at a much, much younger age. And that is what we are all seeing now. And they have long years to go through with diabetes, whether it is pregnancy or out of pregnancy, they have long years to live because of diabetes. What is it that we can do about it? Is there, what is the role of an obstetrician in managing diabetes in pregnancy? Now, glucose metabolism and insulin action. For this, I thought it is better to have an understanding of the glucose metabolism and insulin action in normal pregnancy and what happens in gestational diabetes. The molecular mechanism of insulin is such that it has got the insulin receptor has got 2 sides, one on the cell membrane and one outside the cell membrane. The insulin binds to the insulin receptor. This activates the tyrosine kinase enzyme. And this sets off a reaction where there is phosphorylation of so many enzymes, which are called as insulin receptor substrates. So with this happening, subsequently, there is glucose transport, there is fat synthesis, there is growth and gene expression. So you must realize that insulin action is not limited to glucose. It is extending to fat synthesis, protein synthesis, and a host of other functions. Now, this is just a picture which shows that insulin is now coming and binding at the insulin receptor site. tyrosine kinase is activated, and that causes phosphorylation. The phosphorylation causes activation of this phosphokinase enzyme, which releases GLUT4. Now, the GLUT4 goes into the cell membrane and it allows transfer of glucose inside the cell. I repeat, insulin binds to the insulin receptor, activates tyrosine kinase, phosphorylation, and then there is activation of release of GLUT4. GLUT4 goes on to the cell membrane, allows the entry of glucose inside the cell. So that is the mechanism by which insulin acts. Now, insulin deficiency is the one which causes diabetes, and this could be due to an autoimmune reason where you get the anti-islet cell antibodies. Usually these women are thin and it's of early onset. Then you get monogenic diabetes, which is due to mutation of certain autosomes like MODY and mutations of mitochondrial DNA, etc., and insulin resistance. Now, this is a very important thing because this forms the major component of diabetes in our country, and this is usually of late onset and is often seen in women with obesity. Now, when there is insulin sensitivity, all the actions are in order, normal insulin action, and therefore there is a release of antioxidants also. So the condition is kept in perfect order. When there is insulin resistance, there is reduced insulin action. And because of reduced insulin action, there are various problems, not just limited to glucose metabolism. So this is what you get to see. When there is insulin resistance, you see there is a little glucose outside outside the cell membrane, whereas in an insulin resistant cell, the glucose is all outside. Glucose is required inside, but it is not present, and therefore you get to see hyperglycemia. Now, insulin resistance in normal pregnancy also insulin resistant comes in. This is because the fuel metabolism in normal pregnancy is facilitated anabolism, and it's a diabetogenic stress much later on in pregnancy. If you want to understand what this is, we'll go by this. In early pregnancy, there is an increase in estrogen, increase in progesterone. Now, this causes beta cell hyperplasia. Beta cell hyperplasia causes increased insulin secretion. What is the effect of this hormonal alteration? This is an early pregnancy, increased estrogen, progesterone. This causes an increase in tissue glycogen storage. So glucose is stored away. Like in winter, you tend to store food. The glucose is stored away in different tissues, including the liver. And therefore, there is a decrease in the fasting plasma glucose. So in early pregnancy, the sugar levels fall. And subsequently, the metabolic change that you get to see is that an anabolic effect. Due to increased estrogen, there is hyperinsulinemia, and that leads to anabolism. That is storage of glucose in various tissues. Now, subsequently, after 20 weeks, there is secretion of HPL, prolactin, and then bound and free cortisol. What do these do? This is all coming from the placenta. This causes a diabetogenic or a glucose tolerant state. This makes it insulin resistant. That means though there is insulin, the cells don't respond to insulin. Because the cells don't respond to insulin, there is hepatic decrease in the hepatic glycogen stores because it is released from the liver. And there is a increased hepatic glucose production. Now, the metabolic change that you get to see because of this is that facilitated anabolism during feeding. That means whenever a mother has food, the food is stored away in the liver. But when she doesn't have food, there is accelerated starvation during fasting. When she's not having food, glucose is still released from the liver, and this is a catabolic effect. So why does this happen? This is just to make sure that whether the woman eats or she doesn't eat, there is a continuous supply of glucose and amino acid to the fetus. So when she eats, it is stored away, and when she doesn't eat, the glucose is released from the liver to make sure that the fetus doesn't suffer and it gets a continuous supply of glucose. Now, I told you that there is insulin resistance. The effect of insulin resistance is that there is 50% decrease in insulin-mediated glucose disposal But there is an increase because there is resistance, more and more and more insulin is produced, almost 200 to 250% increase in insulin secretion. So in non-pregnant women, there is insulin secretion, there is a little bit of insulin resistance, but the blood glucose enters and there is normoglycemia. In pregnant women, there is an increased insulin secretion because of insulin resistance. And this increase in insulin secretion helps to maintain euglycemia in the normal pregnant woman. Now, what happens is when the maternal glucose, with regards to various nutrients in the mother that crosses the placenta and reaches the fetus, you will find that the glucose freely crosses the placenta and reaches the fetus. So if the mother has got higher than normal glucose, there is higher than normal glucose in the fetus. The same thing with amino acid. It crosses the placenta freely and reaches the fetus. The ketones also cross the placenta and reach the fetus. So these are three nutrients that freely cross the placenta and reach the fetus, whereas the triglycerides and the fatty acids are not so easily transferred. Insulin and glucagon, two hormones which are responsible for glucose homeostasis in the mother, they don't cross the placenta at all. So they don't reach the fetus. Now, insulin resistance in a woman with gestational diabetes. Now, what happens in a normal non-pregnant woman, when she has food, there is an increase in the blood sugar level. With the increase in blood sugar, there is an increase in the insulin secretion also. In a normal pregnant woman, there is an increased production of insulin, more than a non-pregnant woman. Whereas in a person who has got diabetes, gestational diabetes, the production of insulin does increase, but it is not enough to cover or take care of the blood sugar. It falls short of it, and that is why you get to see hyperglycemia. So this is what happens in normal pregnancy. Insulin resistance is combated by an increase in the insulin secretion, and therefore there is euglycemia. In a woman who has got gestational diabetes, the insulin resistance is not so well combated with insulin secretion, which is lesser than normal, and that is why you get to see hyperglycemia. So GDM by definition is any degree of glucose intolerance with onset or first recognition during pregnancy. So in effect, what happens is when we say GDM, it includes two categories: women with pre-gestational diabetes and women with gestational diabetes. That is diabetes that happens because of the hormonal changes that happen during pregnancy. That is gestational diabetes. A major part of diabetes in pregnancy is gestational diabetes. FIGO modified the term. It said it causes a lot of concern when we keep saying GDM, but we include both. Therefore, it coined the term hyperglycemia in pregnancy. This is the modification in terminology. Hyperglycemia is one of the most common medical conditions women encounter during pregnancy. Now, what are the effects on the mother? What are the effects on the fetus because of GDM? On the mother, whenever if there is hyperglycemia, there is an increased incidence of preeclampsia, preterm labor, and cesarean delivery, and PPH. I would say 3 Ps: preeclampsia, preterm labor, PPH, and cesarean delivery. On the fetus or the neonate, there is an increased incidence of abortions, congenital anomalies, IUGR, macrosomia, stillbirth, birth injuries, hypoglycemia, hypocalcemia in the neonate, and even hyperbilirubinemia. So these are the problems. So when they ask you to write about the risk due to GDM, you can classify them as short-term risks and long-term risks. Short-term risks include in the mother preeclampsia, preterm labor, PPH, and cesarean delivery. And in the fetus, it includes abortions in early pregnancy, congenital abnormalities, growth restriction, and macrosomia, that is affecting the growth, stillbirth, birth injuries, and in the neonate, you get to see hypoglycemia, hypocalcemia, and hyperbilirubinemia. Now, is that all? Does the risk limit to pregnancy and delivery? Not at all. There are certain long-term risks due to GDM, both in the mother and in the child. In the mother, if you find a mother having gestational diabetes, she is definitely prone for frank diabetes, that is either type 2 diabetes in the coming years. her chances of developing hypertension and cardiovascular disease are all increased. And in the child, a neonate born to a mother with gestational diabetes soon grows up to become obese. It also develops metabolic and cardiovascular diseases. And surprising to know that there can be a lot of neurological and psychological problem because of hyperglycemia in the mother. So I told you maternal morbidity is because of all these problems: polyhydramnias, hypertension, preeclampsia and eclampsia, abruptio placenta, preterm labor, cesarean delivery, and postpartum uterine atony. Now, how does the hyperglycemia affect on the fetus? When there is fetal hyperglycemia in very early pregnancy, that is because of pre-gestational diabetes, you will find that there is an increase in the incidence of congenital anomalies and decreased early growth, that is in the first trimester itself, and there is hyperinsulinemia. Now, subsequently, it develops fetal hyperglycemia in the mother, gives rise to hyperglycemia in the fetus, which stimulates the fetal pancreas by 16 weeks to produce more insulin to combat the increased blood sugar levels. This gives rise to neonatal hypoglycemia soon after birth. There can be surfactant deficiency, which can give rise to respiratory distress syndrome. And because the liver is immature, it can give rise to jaundice. Fetal hyperglycemia can also give rise to macrosomia, growth problems, and this can give rise to birth asphyxia, cardiomyopathy, TTN. There can also be fetal hypoxia, polycythemia, and problems because of polycythemia, which include stroke and venous thrombosis. Now, the possible abnormalities in the offspring of a mother with diabetes include they are dependent on the timeline at which hyperglycemia occurs. In the first trimester, the congenital abnormalities include, it gives rise to congenital malformation. The second trimester, macrosomia, CNS developmental delay, and early IUGR. Because the organs are already formed, there is a problem with the growth of the organs. Either there is an increased growth or a decreased growth. So you get to see FGR, you get to see macrosomia, and sometimes if the glucose is not well maintained, if the sugar values are not well maintained, you get to see even intrauterine death of the fetus. Then in the newborn, it can give rise to all these problems: RDS, hypoglycemia, hypocalcemia, all the problems that I just enumerated. In the child and adult, the birth injury that has happened, say Erb's palsy or Klumpke's palsy or fracture of the clavicle, all these can give rise to behavioral problems. Along with that, there can be a behavioral deficit, intellect deficit, obesity, and diabetes. So like I said, it depends upon the timeline. Within the first 2 weeks, before she misses the period, if there is hyperglycemia, usually it does not give rise to teratogenesis. But immediately afterwards, the third and fourth week, even before she misses her periods, you will see that the neural tube defects can come in, because that's the time when the a neural ridge is formed, and therefore you get to see the neural tube defects, and then you get to see the cardiac defects, and then amelia or meromelia, and then cleft lip, and all the other gastrointestinal and skeletal abnormalities can come in. So the potential teratology, either it can give rise to organ problems, congenital malformations, or it can cause behavioral problems. But all this is limited to pre-existing diabetes. The gestational diabetes, that is, if a woman was normoglycemic at the start of pregnancy and develops diabetes when she reaches 24 weeks, then that would be called gestational diabetes. There, you don't get to see congenital malformations or behavioral problems. These babies tend to have anthropometric problems, that is macrosomia or sometimes FGR.
I didn't catch that. Could you try again?
The congenital malformations overall incidence is 5 to 9%. It is 2 to 3-fold higher than general population, predominant in infants of diabetic mothers, and the malformations of CNS is seen most often. No malformation is considered pathognomonic except the caudal regression one. No increase in major congenital malformations among the offspring of diabetic fathers. Like if the father is diabetic, then it doesn't matter. Or if she's a pre-diabetic woman or GDM after the first trimester. So all this suggests that the glycemic control during embryogenesis is the main factor for malformations. Frankel in 1980 coined the term fuel-mediated teratogenesis. Now, what it means is normally when we take a fuel, that is food that we take, is supposed to nourish the body. But in this situation, the food that is taken, the glucose that is taken can give rise to congenital abnormality. It can give rise to teratogenesis. That is why he coined the term fuel-mediated teratogenesis in diabetes. Exposure of the embryo to an abnormal metabolic environment during the initial stages of embryogenesis results in abnormal development of the embryo. Now, what is the reason that these congenital malformations come in? It could be due to hyperglycemia, it can be due to hyperketonemia or oxygen-free radicals. All these are known to cause. Hyperglycemia can cause structural changes, decrease embryonic size, yolk sac malformations. Anyway, I don't think you will need to go into the details of this. Suffice it to understand that the reason for congenital malformations have varied. There are a lot of theories that have been put across. I picked up the three most common ones. One is hyperglycemia. Second is hyperketonemia, which is due to increased beta-hydroxybutyric acid. And exposure to increased beta-hydroxybutyric acid can cause teratogenic problems and long-term neurodevelopmental abnormalities. The third reason they say that hyperglycemia causes congenital malformations is that this is a release of oxygen-free radicals, which result because of increased glucose metabolism, and that can have a direct effect on the DNA and cause problems. Now, you know, caudal regression syndrome is 600 times more frequently seen among IDDM, but it is not one of the common malformations, but it is sort of specific to infants of diabetic mothers. And the other problems that you get to see is neural tube defects and microcephaly. And like I said, spectrum of cessation of growth of the rostral portion of the spinal cord. This portion stops growing. Abnormal neural, muscular, skeletal, and vascular components are there. Cyrinomelia. Cyrinomelia is a kind of a mermaid. I saw one such baby only during my postgraduate days. And this is again due to diabetes, could be due to diabetes, but it can be due to other problems as well. Absence of hind limbs, where both the lower limbs fuse and in a mermaid fashion. Cardiac problems are transposition, VSD, coarctation, atrial septal defect, hypertrophic cardiomyopathy. The one important problem in the cardiac, one functional abnormality that can result because of diabetes in pregnancy is hypertrophy of the ventricular septum, which can give rise to cardiac failure after the baby is born, and one is vigilant. And this is a functional problem because once the baby is managed, supportive care is given, the abnormality in the neonatal heart sets itself right, and there is no further problem. There are two functional congenital malformations in the fetus. Functional meaning only by function they are a problem. One is the hypertrophied ventricular septum, and the second one is congenital left colon syndrome. Renal problems, hydronephrosis, renal agenesis, and ureteral duplication. Diurnal atresia is very common among women who, fetuses of women who have had diabetes. Again, anorectal atresia, I have seen some of my patients who have had diabetes, their children have had anorectal atresia. And the functional problem, like I told you, is the small left colon syndrome. And in the second trimester, I told you it can cause growth abnormalities. It can give rise to polycythemia, hyperbilirubinemia, and cardiomyopathy. And so macrosomia is one major problem in an infant of diabetic mother. It is birth weight more than 4,000 grams. but the more common term would be large for gestational age when it is more than 90th centile. What is pathognomonic of an infant of diabetic mother is the distribution of the fat, which is in the interscapular region, and therefore increases the bisacromial diameter, and that causes problem at the time of delivery because the head passes through the pelvic outlet, whereas the shoulders get stuck at the brim of the pelvis, and therefore giving rise to shoulder dystocia and various problems at during labor. So in this macrosomia is because insulin and insulin-like growth factors are increased, and they cause an increase in the growth of the fetus and abnormal adipose deposition. The visceral organ hypertrophy happens, like, all the organs inside the abdomen, which includes the liver, the spleen, and all the organs increase. And because of hypertrophy of the visceral organs, you will see an increased abdominal circumference as well. The skeletal growth also increases. And this is also because of increased levels of lipids, ketones, and amino acid that stimulate insulin secretion. And insulin is like a growth hormone to the fetus. Growth restriction can happen. Like on one hand, you could see excessive growth, macrosomia. On the other hand, you could have growth restriction. And this could be as high as 20%. Most often, it is due to maternal vascular disease or due to placental insufficiency. Now, women with the, diabetes in pregnancy or hyperglycemia in pregnancy is more prone to develop preeclampsia or even hypertension in pregnancy, and that causes a reduction in the flow of blood across the placenta to the fetus and can give rise to FGR. It could also be due to chromosomal abnormalities. Now, birth asphyxia happens because of various reasons. One, prematurity. Second, because of growth disorders. And then maternal vascular disease, placental insufficiency can give rise to problem. And peripartum maternal hyperglycemia also can give rise to fetal hypoxia. So that is a major problem. Hypoglycemia in the fetus is because of maternal hyperglycemia. This is called the Pedersen hypothesis. Maternal hyperglycemia causes fetal hyperglycemia because the glucose freely flows across the placenta to reach the fetus, and the fetal blood sugars go up. That stimulates the fetal pancreas to produce more insulin, so you get to see fetal beta cell hyperplasia. Now, the fetus is able to manage the blood sugars, its high blood sugars, with the help of increased insulin production when it is inside the uterus. Now, once it is outside, once delivery has happened, the extra sugar that was coming from the mother is no more there, but the baby's insulin levels are quite high. So it is like taking a shot of insulin, but no food after that. Therefore, it can give rise to hypoglycemia in the fetus. So, respiratory distress syndrome is 3 to 5 times more common in diabetic women as compared to in infants of diabetic mothers as compared to a normal pregnant woman. The contributing factors is due to prematurity, lung maturity gets affected, and if the sugar control is poor, there is an increase in the incidence of respiratory distress syndrome. Hyperinsulinemia decreases or inhibits the number of type 2 pneumocytes, and the choline uptake in type 2 pneumocytes is reduced. Steroid-enhanced phospholipid synthesis is obstructed, and therefore you get to see a decrease in the number of lamellar bodies and in the production of surfactant protein A. So therefore, these babies whose mothers have had diabetes do tend to have increased incidence of respiratory distress syndrome. Hypertrophic cardiomyopathy, like I told you, is one of the common problems that can be seen in the neonates. This is actually a manifestation of generalized organomegaly. All the organs hypertrophy, and similarly, the heart also. And there is also, because of increased catecholamines, there is hypertrophy of all the chambers of the heart, asymmetric ventricular septal hypertrophy. But the valves and the great vessels are all normal here. So usually it resolves in 6 to 12 months, and most often the infants are asymptomatic, and even if they are symptomatic, with a little supportive care, they do extremely well. Polycythemia is due to various problem, respiratory distress and decreased renal function. It can give rise to problems like thrombosis, renal vein thrombosis, necrotizing enterocolitis, etc. So one needs to be aware of polycythemia. Polycythemia can also contribute to hyperbilirubinemia, prematurity. Hyperbilirubinemia can happen because of prematurity, because of polycythemia, and it can also happen because of birth trauma, like whenever there is an injury to the abdominal viscera, or if there is a cephalohematoma, or if there is any bruising at birth, that can give rise to, that amount of extra bleeding can give rise to an increased bilirubin level. And therefore, hyperbilirubinemia is something that we need to watch out. The long-term effects in the offspring are anthropometric. Like I told you, they tend to be obese, they tend to become diabetic at a much earlier age, and they also tend to have neurological and psychological problems. Now, I will not go into this. We will go into screening for just now that we know that these are all the problems in the mother and problems in the fetus because of gestational diabetes. So we'll need to go into how do we tackle this problem. You must understand that most diabetic women are not, diabetic pregnant women are not symptomatic, and you can pick up the problem only by doing a test, only by checking their sugars. Now, earlier there was a question, should we test all women for diabetes, or should we choose only those high-risk women for diabetes? Those who have delivered big babies, those who have had a previous stillbirth, or those who have a strong family history of diabetes, etc., etc. But now in India, since every other person is found to be diabetic unless proved otherwise, it is universal. That means we check all our pregnant women for diabetes. Now, the 4th International Workshop Conference on Gestational Diabetes, way back in 1997, what we knew then was that overt diabetes clearly increases the risk of adverse pregnancy outcome. We knew that if a woman is diabetic, even before she starts pregnancy, if we know that she is diabetic, then her pregnancy outcome can be hampered. There can be problems in pregnancy, and it can adversely affect the outcome. But what we didn't know till then, till 1997, is that what level of glucose intolerance short of diabetes, that means before you make a diagnosis of diabetes, levels less than those used for diagnosis of diabetes is associated with the risk of adverse outcome. So to that effect, this particular HAPO study was conducted. This involved 25 countries, and this is called as the hyperglycemia and adverse pregnancy outcome study. So a lot of women, almost 25,000 women were enrolled. What they did was to give a 75-gram 2-hour OGTT between 24 and 32 weeks of gestation. So they had two, this one, both the subjects and the caregivers were blinded to the GTT results. That means it was a randomized controlled trial. Nobody knew, and it was double blinded. Only if the fasting plasma sugar exceeded 105 or the 2-hour value exceeded 200, that means only when they were frank diabetes, they were not included in the study. All the other women and their caregivers were this one. Then they were categorized into different levels, less than 75, 75 to 79, 80 to 84, 85 to 89. Every 10 milligram was made into one group. So you had about 7 groups in all. And then sugars were checked at 1 hour and sugars were checked at 2 hours in all these women. Then they checked the association of the glucose with the primary outcome. So what was the primary outcome? The primary outcome was how many of them underwent primary cesarean section. How many in group 1? That means less than 75, 75 to 70 to 80, 80 to 90, 90 to 100, that kind. So how many of them in these different groups develop underwent cesarean section, how many in the different groups underwent hypoglycemia, neonatal hypoglycemia, and they checked the cord C peptide, the umbilical cord C peptide reflected the insulin levels. So they checked the cord C peptide, and based on that, they realized that even lesser sugar values than those that were used to diagnose diabetes could give rise to increased adverse pregnancy outcome. So the International Association of Diabetes and Pregnancy Study Group decided, based on this, that if a fasting was more than 92, 1 hour was more than 180, and the 2 hours blood sugar was more than 153, any one of the values was high, then you would diagnose gestational diabetes or diabetes in pregnancy. So they came up this one cutoff based on the 1.5 odds ratio. So you give them 75 grams OGTT, and if this was the cutoff, you choose any one value was high, then it was taken as diabetes. But why do we need to have our own test? Why can't we follow the IADPSG? The urgent need for universally applicable simple screening procedures and diagnostic criteria for GDM. The World Diabetes Foundation found out that people in many countries, especially developing countries, it was not, gestational diabetes was not diagnosed at all because to do those tests was found very difficult. Issues with the traditional test, pregnant women can't come fasting. Many of them don't come back for the diagnostic test if the second step was used. It was expensive, and each one was doing a different kind of test, and some of them didn't do the test at all. So FIGO finally said that based on the condition, based on the availability, a pragmatic solution should be taken, and the country should base the diagnosis of diabetes based on this. So DIPSI, that is Diabetes in Pregnancy Study Group India, came up with our test. 8 countries account for 55% of the global live births, and these 8 countries needed a different kind of test that could be done fairly easily. So came the DIPSI test, or the single step test. Now, according to the DIPSI, it is a one-step procedure. Now, earlier tests, the one of Carpenter, Costin, etc., included give a 50 grams glucose, then 1 hour later check the blood sugar. If it was more than 135, 140, then you subject them to the 100 gram OGTT. DIPSI said, no, we will do only one method. This is for screening, this is for diagnosis also. And this one-step procedure involved irrespective of the previous meal, because you can't ask a pregnant woman to come on an empty stomach. If she did come on an empty stomach, it would be several hours from the time of her previous last meal. Like, for example, if you ask a woman to come for an OGTT, she would have had a dinner at 8 or 9 in the previous night. She will finish all her household work and then she will come for the test, which means even if she did get up at 6 or 7 in the morning, she would present herself to the hospital around 9 o'clock, which would mean long hours of fasting. It's not practical for a pregnant woman. So it said that give 75 grams of oral glucose in 300 ml of water and check the blood sugar or plasma sugar 2 hours later. This is simple, economical, and feasible. So how do you decide what is the thing? If the sugar 2-hour plasma glucose is more than 200, then you diagnose diabetes. If it is between 140 and 199, you would label her as GDM. If it is between 120 and 139, you would still not let her go. You will call it as gestational glucose intolerance. That means many of these women who develop, who have values around this are likely to develop diabetes when you check sometime later. And less than 120 is considered as normal. Check for diabetes in pregnancy. Why? First trimester is important. First trimester or at booking, and 24 to 28 and 32 weeks. What are the benefits of early testing? Now, supposing you don't check for sugars in early pregnancy, unrecognized type 2 diabetes mellitus will go completely missing. Supposing you don't check in at booking or at say 7-8 weeks whenever she comes to you. Fetal hyperinsulinemia in response to maternal hyperglycemia occurs by 16 weeks. Now we know it is even much earlier. This leads to accelerated growth despite good metabolic control in later pregnancy. You might have perfectly managed sugars, but if you have missed out the first trimester hyperglycemia, then already the fetal hyperinsulinemia has kicked in, and therefore there can be increased fetal growth. So if it is negative in the first trimester, you repeat it at 24 to 28 weeks, and then again between 32 and 34th week. It's a single step test, one-step procedure, irrespective of the previous meal. And what if she vomits after taking it? If she vomits within half an hour of taking the glucose, repeat the test on another day. More than half an hour after taking glucose, go ahead and draw the blood sample at 2 hours. So the advantages are you get to do the test for a lot of women. It's suitable for Indian setting, saves time, saves costs, and avoids repeated visits. So implications of GDM, benefits of treatment. Now we established, supposing we do diagnose, we established that with the HAPO study, we know that lower blood sugars can have adverse pregnancy outcome. Okay, you identify GDM women. Having identified, with treating them or bringing to euglycemia, will it reduce all the adverse outcome? That needed to be established. The AKSHARAM study, that is the Australian carbohydrate intolerance in pregnancy study, looked at 1,000 women. They had two groups. Two groups of women, one in Adelaide, another one somewhere else. And it was a randomized control study. In one group of women, they gave routine care. The other one, that is the intervention group, where they identified the blood sugars and treated the blood sugars with medical nutrition therapy and insulin. They wanted to find out what happens if you treat them. So when they did give the treatment, they found that in the intervention group, all the adverse outcomes was reduced, and they had better quality of life scores than in the routine care group. So we established, this study established the fact that treating GDM is going to improve the pregnancy outcome. So how do we manage hyperglycemia in pregnancy? How do we go ahead? Now, once we have done the diagnostic test, we have picked up diabetes, how do we manage hyperglycemia in pregnancy? Now, there are two aspects to this management. One is the glycemic management. The other is the obstetric management. That is what an obstetrician does. And of course, glycemic management also has to be managed in several institutions by the obstetrician herself. Now, you must notice here that the pattern of glycemia in normal pregnancy is that the fasting blood sugar is as low as 71 plus or minus 8 milligrams, 70 to 80. And the 1 hour blood sugar, that is 1 hour after meal, the blood sugars are close to 110. And 2 hours after meal, it is close to 100. So the blood sugars are much lesser, much lesser in normal pregnancy as compared to a non-pregnant woman. So therefore, the targets for glycemic control would be a fasting plasma sugar of 80 to 90, a 2-hour post-meal of 110 to 120. So with this, we would expect the birth weight to be anywhere between 2.5 to 3.5 kg. Now, how do we bring a control in the blood sugars, glycemic control? One is decrease the glucose load. If you give big load to the mother, if by way of a diet, then the blood sugars will go up. So decrease the glucose load, decrease the insulin resistance, and increase insulin. So these are three ways of tackling the blood sugars. How do we do that? So decrease the glucose load by bringing modifications in the diet. How do you decrease the insulin resistance? You increase exercise. Whenever a diabetic woman exercises, the blood sugars come down by 5 to 10 milligrams. This is because of peripheral uptake of glucose by the skeletal muscles. So when you exercise, the skeletal muscles mop up the glucose, and therefore the blood sugars come down. So that is decreasing insulin resistance. Metformin also acts by decreasing insulin resistance. Increasing insulin is by drugs. There are some drugs like insulin and glyburide. Both increase the insulin. So these are three ways of bringing glycemic control. Non-pharmacological glycemic prescriptions include diet modifications and increasing exercise. Now let us look at what modifications we can make in the diet. You should tell them to reduce the grain size. When I say reduce grain size, no going beyond two numbers, 2 idli, 2 dosa, 2 roti, 2 chapati. No going beyond one soup bowl size of rice or upma or poha. Soup bowl size, not, the bowl size has to be very clear. It has to be a small bowl. So when they are eating rice, upma, poha, it should be that small. Frequency and timing. They should be taking 3 small meals and 5 snacks. So 3 meals and 3 snacks, fixed time for all the meals. Now, the idea is when you give a small glucose load, the excursions in the blood sugars are going to be relatively small. When you give one big load, the excursions is going to be quite high. So instead, distribute the food throughout the day by giving small meals. And if she feels hungry, one snack in between. So that is how you increase the frequency and increase the number of times that she takes. And the protein source is very important. She needs to have, because of pregnancy and protein content in the meal is very much important for bringing down the blood sugars. Paneer, soya, dal, lentils, sprouts, etc. So she needs to avoid bakery items and packaged food, biscuits, etc. Increase fiber, that is, include maximum non-starchy colored vegetables. Now, fiber, at least she needs to have 25 grams of fiber, which can be present in about, she should have at least 300 grams of vegetables a day. And another 200 grams of fruits which are not high in sugar content. So the larger the quantity of vegetables, better is the control of sugars, because the fiber binds the sugar and does not allow the sugar to the glycemic spikes. So high protein Indian meal and salads include this. I've just put some examples here. We do have a lot of high protein Indian meal. They don't have to buy bottles of protein mixtures, etc. And if you are working in an institution, a public health institution, then you may not have the luxury of a dietitian to guide the meal. So you will have to do it yourself. So this is called as a plate meal method of portioning out meals. This is from the ICMR. You need to fill half the plate with starchy vegetables. In the other half, quarter size protein, which includes dal or non-vegetarian chicken, etc. And quarter is of starch, which includes your roti, rice, ragi, etc. And very little oil, ghee or oil needs to be there. Now, when it comes to exercise, most of our pregnant women think that pregnancy is a condition where they need to take it easy. They should not be exercising, which is not true at all. There are hardly any, very few conditions in pregnancy where you would advise them not to exercise. And maybe even there is no question of bed rest. It is only restricted activity. Exercise include 30-minute moderate intensity activity. It can be aerobic or low resistance exercises. 15 to 20 minutes of moderate activity after a meal helps to keep the sugar levels within the target range. And preferably upper body low resistance exercises are recommended. Any exercise, if she has been doing before, she can continue to do. The simplest form of exercise is walking. Weight training of the arm muscles using half to 1 kg weight. Like they can take water bottles in each of the hands and do weight training. Weight training also decreases the amount of, decreases sugar values. Static resistance exercises like wall push-ups, wall squats, moderate intensity and duration 30-minute session, at least 150 minutes of activity spread throughout the week. That doesn't mean that they exercise now and then the rest of the time they sit on the sofa, which is not good. We have a lot of younger women now who are into the IT industry, and even if they are not working in the IT sector, most of them have work of long hours in front of a laptop, or they are watching the TV. So this says that this study by Anjana et al. Says that sedentary behavior, sitting on the sofa for more than 15-20 minutes a day, confers a 3.8 odds ratio for adverse neonatal outcomes in GDM pregnancy. So encourage moving, keep moving all day. Now we'll come to pharmacological prescription. We are talking about insulin, metformin, glyburide or acarbose there. Now we have enough study which says that glyburide, which we were using before, is now out because of the risk of neonatal hypoglycemia and increased NICU admissions. So glyburide is out. Metformin, we have enough studies, even the latest one in 2021, which is comparable to insulin for pharmacotherapy in gestational diabetes. So this was a meta-analysis and it found that it was good. A review in the frontiers, and this is in 2023. It says that metformin effects on the mother, it decreases miscarriage risk, identical preeclampsia risk, identical cesarean birth, gestational weight gain is reduced. Its effects on the fetus includes, it reduces the incidence of congenital abnormalities, preterm birth, birth weight and height, and long-term, the effect is an increased weight in the neonates. So metformin can be, according to the Mental Health Division, Ministry of Health and Family Welfare of Government of India, metformin can be considered after 20 weeks for the medical management of GDM. And the dose of metformin is 500 milligram twice daily orally. Please remember, metformin is a medication that is given after food. It is not given before food. It is given after food. Initially, you can start with 500 milligram twice a day. A maximum of 2 grams a day can be given after a meal. Now, which are those women who form good candidates for metformin? Ideal candidates are those where the fasting blood plasma sugars is just a little bit above normal. It's less than 100. Later gestational age at the time of treatment. Supposing you see this, you pick up GDM when she's about 34, 35 weeks, then this is probably a candidate. No previous history of GDM and lower BMI. If it is an obese woman, even if the sugars are just on the borderline, it would be ideal for us to put them on insulin because, she's likely to develop more insulin resistance than a woman who's non-obese. Unique advantage is lack of maternal hypoglycemia. Now, metformin doesn't produce hypoglycemia in the mother, unlike insulin, unlike glyburide, etc. It is simple, easy to administer, and more acceptable for the women. Patients who are more likely to require supplemental insulin include fasting plasma sugars more than 110. If the baseline sugars are high, or if you pick up gestational diabetes at an earlier rate, say at 24 weeks when you did, or when the diagnosis, if she had GDM in previous pregnancy, then, or when she is a very obese woman, more than 35, she's like, metformin will not be enough, you will have to give insulin. So traditional management of GDM is diet, exercise, and insulin. Why insulin? Because it does not cross the placenta and is extremely safe for the fetus. When do we start insulin in GDM? Which are those women where we give insulin? At diagnosis, along with MNT, if the sugars are very high. Supposing when you're diagnosed, the sugars are quite high, then along with the MNT, you don't wait for the MNT to work and then start her on insulin. You give it along with MNT. After MNT, if fasting plasma glucose is more than 90 and 2-hour plasma glucose is more than 120, then you will definitely, you find that despite MNT, the sugars are not controlled. That is when you would give insulin. Now, what are the insulin requirements in pregnancy? If she has got a pre-gestational diabetes mellitus, then in the first trimester, you give 0.7, second trimester, 0.8 units per kg per day. In the third trimester, 0.9 units per kg per day. And at term, you give 1 unit per kg per day. Then you calculate the dosage of insulin, give 2/3 in the morning and 1/3 at night as a thumb rule. Basically, this is just to start off. And then you monitor the blood sugars and then you adjust the dosage of insulin. If you find that the sugars are much lower than what you want it to be, then you decrease the dosage of insulin. If you find that the sugars are much higher, then you can increase it by 2 units. Increase it by 2 units, watch for the next 2 days, and then increase it further if it is still not under control. Women with GDM, usually the requirement is variable depending upon the time of onset of diabetes and severity of hyperglycemia. Now, insulin regimes, how do you give insulin? Usually in gestational diabetes, that is those who develop diabetes, hyperglycemia because of pregnancy, once daily insulin may be enough. You give just 1 time a day, that should be enough. If the fasting blood sugar is high, then you probably give twice a day. Usually you give a pre-mixed insulin, like a Mixtard. Mixtard contains intermediate acting insulin and fast acting insulin. So it's a mix of 2 kinds of insulin. So that you give twice a day based on the requirement. In type 1 or type 2 diabetes, you will need to give 3 doses of insulin along with each meal. At least 3 injections of insulin daily. And sometimes you need to give a long acting, just before bedtime, you will need to give a long-acting insulin. This is in women who have pre-gestational diabetes. So insulin mixtures are 30 to 70 or 50 to 50 Mixtard, regular and isophane. Multiple injection regimes, which include give Mixtard with breakfast in the morning and before supper. Or you give regular and Mixtard, or you can give regular insulin, regular insulin, regular insulin. These are fairly short-acting insulin, and intermediate insulin at bedtime. Now, supposing the fasting is 85, breakfast is 155, lunch is 145, dinner is 140. Fasting seems okay. It is the post meals that are high, 155, 145, 140. They are all above 120. So you will give 6 units of regular insulin before breakfast, before lunch, before dinner. So dosage adjustment, titration of dose is based on the self-monitoring of blood glucose value. If FBS is more than 90, increase the night dose by 2 to 3 units. If 2 hours post-lunch is more than 130, increase the morning dose by 2 to 3 units. Supposing she has hypoglycemia, reduce 2 units both the times. So this patient, fasting is okay, breakfast is okay, lunch is okay. It's only the dinner that is high. So what we do is, along with the 8 units of Mixtard, you add 6 units of regular insulin at dinner time. This should bring the sugars under control. Now, a small word about insulin analogs. All these insulins, that human insulins, are all biological insulin. Insulin analogs are synthetic insulins. Synthetic insulins are recombinant insulins, insulins that are manufactured in the lab. What is the advantage of this? The advantage is that they are rapid acting, they act very quickly, so they can be taken with the meal. They match the insulin production in the body. Just how the human body produces insulin, it is produced, or it acts the same way. Regular insulin, when you give the regular insulin, there is a delayed peak action and early and high postprandial glucose. Whereas with the insulin analog, there is a rapid rise in the plasma insulin concentration within minutes to a higher peak, which then falls more rapidly. So the postprandial hypoglycemia is avoided and preprandial hyperglycemia is avoided. The merits of insulin analogs, synthetic insulins, they better mimic the physiological insulin secretion, better control of postprandial blood sugars, better control of glucose levels in the fasting and interdigestive period, lesser risk of hypoglycemia, and the action is very predictable. And greater flexibility can be given with meal. Like, the human insulin, if you give within the next half an hour, they should have food. If for some reason there is a delay, they can go in for hypoglycemia. So that's a problem. So the insulin analogs, rapid acting Lispro, Aspart are given during pregnancy. Glargine is not approved. The long-acting Detamir is approved. Glargine is not approved for pregnancy, but if a woman is on Glargine even before the pregnancy started, it can be continued during pregnancy. Which are those women in whom you give insulin analogs. Women with uncertain lifestyle, quantity of meals. Supposing she's an air hostess, the time zones vary and she won't know when to take. So those are the kind of women who do better with insulin analogs. It's not controlled by standard. Supposing the sugars are not controlled with the regular insulins, then you would like to add analogs. Or if the high unpredictable fasting and postprandial blood sugar, so the risk of hypoglycemia, especially nocturnal hypoglycemia, then you would want to give insulin analogs. Now, where to give insulin? First trimester, there is no change inside. Second trimester, lateral parts of the abdomen staying away from the skin overlying the fetus. In the third trimester, it can be injected even over the abdomen while ensuring the skin fold is properly raised, like this woman. Like you raise the skin fold and take. Or it can be taken on the anterior aspect of the thigh or in the arm. Okay. Insulin pens, are they useful? Yes, because they make it painless. They are 31 gauge and acceptability is high. Convenience and ease of use. Accurate dosing is possible with insulin pens. Insulin pumps are making a way into our clinical practice. This is used in pre-gestational type 1 diabetic women. Quite often, they're already on insulin pump when they come to us. It checks glucose level in the interstitial fluid, which mimics blood glucose. And insulin pumps are very helpful in identifying glucose variability, which may not be possible by the point checks with SMBG. How tight should the control be? Unlike the non-pregnant women, we need to have a very tight control in the blood sugars to the extent that the fetus no longer recognizes the mother as diabetes. That would be the first step in the prevention of diabetes and obesity in the offspring. Now, let us look at the obstetric management. So far, we looked at the glycemic management. Let us look at the obstetric management. So, women with pre-existing diabetes need care right from the first trimester onwards. All women need care, but special attention to diabetic women and women with pre-existing diabetes or pre-gestational diabetes, they need care right from the beginning. Women with gestational diabetes will need care from the time of detection. That is sometime after 24 weeks, whenever they are picked up. So in the first trimester, this is in terms of pre-gestational diabetes. In the first trimester, the mother, you check the blood sugars, you get the HbA1c done, which is a glycosylated hemoglobin. The glycosylated hemoglobin reflects the sugar values in the previous 3 months, how good the sugar control was. So it gives us an idea of the possibility of complications that can happen. A retinopathy should be checked. So a fundus examination is compulsory for all women with pre-gestational diabetes. Check for nephropathy by getting at least a minimum serum creatinine done. Electrolytes can also be done and creatinine protein ratio can be checked out. So this is important in the mother first trimester if she had pre-gestational diabetes. In the fetus, you need to get a dating scan because these babies can have growth problems later on. Unless you have a dating scan, you don't know what to do. Scan at 11 to 13 weeks, that is the NT scan that we call. And the biochemical screening with beta-HCG and PAPE. Minimum double marker has to be done. The second trimester, apart from monitoring the blood sugars, you again do a fundoscopy and check for nephropathy. In the 18 to 20 weeks, you get a fetal echo. No, after 20 weeks, you get a fetal echo done and the 4-chamber view of the outflow tracts for women with pre-GDM. An anomaly, a detailed anomaly scan is important in a woman who has got pre-gestational diabetes. In the third trimester, apart from monitoring the blood sugars, again you check for nephropathy and retinopathy. You look for proteinuria, you look for hypertension, you check the serial fundal height, look for growth abnormalities in the fetus. In the fetus, you need to get a growth scan done more frequently. And that is at 28 weeks, 32 weeks, 36 weeks, and more frequent if there is placental insufficiency. From 32 weeks onwards, you would probably get an NST done and a Doppler. If there is placental insufficiency, you will need to get a Doppler done. Test for fetal well-being from 38 weeks onwards, and you will need to plan delivery. Now, biochemical markers in diabetes pregnancy, you will need to know when you are sending a requisition for a double marker, when you are sending the serum sample, you will need to mention that this woman is diabetic and she is on insulin or whatever, because the levels of alpha fetoprotein, conjugated unconjugated estriol, inhibin A, etc., they are all significantly reduced in women with diabetes. So a correction factor needs to be applied at the lab. If you do not mention that she is having diabetes, that correction factor may not be applied, and you might get a report which should suggest Down syndrome. Therefore, the multiples of median values should be adjusted in women with diabetes. Now, growth, we monitor the growth of the fetus, and the most important biometry is that of the abdominal circumference. It's the best parameter which correlates with the nutritional status of the fetus. Even a growth-restricted fetus or a macrosomic fetus, you check the abdominal circumference, you get to know what is happening to this fetus. When it is more than 75th centile and a rising trend in the fetal growth pattern of scans done at 24 to 27 weeks and at 28 to 31 weeks predicts fetal macrosomia. So you have to have growth charts. Just a report will not be enough. You will definitely need to have growth charts. Here it is within the centile, 58th centile. Here you find that it is rising up. And then it is rising up further. It is reaching the 75th centile. When you look at the abdominal circumference, here it is at the 50th centile at 24 weeks, and subsequently by 28 weeks, it is already reached the 95th centile. You will see that here it is at the 50th centile at 24 weeks, and then by the time she has reached 30 weeks, it has crossed the 70th or 75th centile. And by 33 weeks, it has reached the 95th centile. So a rising trend in fetal growth rate pattern is picked up, and you diagnose macrosomia. So prediction of macrosomia and ultrasound, abdominal circumference is the single most important and reliable parameter in predicting macrosomia. You can either take it like this or you can take it like this. Now, I also told you that women with gestation, with diabetes or hyperglycemia and pregnancy tend to have hydramnios. So why is there hydramnios? Because of increased glucose in the mother, there is an increase glucose in the fetal compartment, and therefore the fetus produces more urine, the amniotic fluid is increased, plus there is more production of amniotic fluid by the membranes because of the irritation by the glucose. So you will find hydramnios is a prominent feature in women with diabetes in pregnancy. And when there is hydramnios, with or without hydramnios, preterm labor is a common problem in women who have diabetes. So if a woman comes to you with preterm labor, the preferred drugs, tocolytic drug that we give is magnesium. We don't give magnesium sulfate, of course, nifedipine and indomethacin. Beta mimetic drugs, like some are used to giving isoxsuprine hydrochloride, ritodrin. These are not preferred because these drugs by themselves can give rise to hyperglycemia. So if they come in preterm labor, the drug of choice for preterm labor is nifedipine. Indomethacin is preferentially used in women who have got gross hydramnios and are finding it difficult, because indomethacin reduces the amniotic fluid. Now, you also want to give antenatal corticosteroids when they come in preterm labor, because it reduces the incidence of RDS, etc. But you must remember that when you give antenatal corticosteroids, there is a rapid deterioration in the maternal glycemic control and even precipitation of diabetic ketoacidosis. So those only on diet may need insulin. Those on oral anti-diabetic agents, that is metformin, will need insulin. Those on insulin will need an increase in the dosage of insulin. If she was taking 8 units, you will have to make it 12 units. So up to 40% increase in the first 3 days and up to 20% increase in the next 2-3 days. However, if she has already reached 37 to 39 weeks, you probably don't want to give them antenatal steroid because it can increase the incidence of neonatal hypoglycemia. It doesn't reduce the incidence of neonatal respiratory problems. That is the intention why we give steroids. But it can increase the incidence of neonatal hypoglycemia. So just up to 34 weeks, you would like to give antenatal corticosteroids. If you do want to give steroids, if she comes at 37 or 39 weeks, whatever, because you think she is diabetic and this baby is likely to develop RDS, you have to mention it in the charts and do so. Stillbirths in GDM is more common with pre-gestational diabetes, especially where the sugars are not well controlled. This is because increased insulin, increased growth of the fetus, therefore increased oxygen consumption, and that can give rise to acidosis. Also, if there is maternal vasculopathy, it can give rise to placental insufficiency, that can give rise to fetal hypoxia and acidosis. Can we predict stillbirth with fetal Dopplers? Now, in IUGR, we know if there is diabetes in IUGR, fetal hypoxemia, there is a classic redistribution seen in fetal Dopplers. So you can pick up which are those fetuses that are likely to land up in intrauterine death. But in diabetes where there is macrosomia, there may be acute fluctuations in the fetal blood pH due to fluctuations in the maternal glucose concentration. So this metabolic derangement in the fetus may lead to acidemia, but without hypoxemia. Therefore, you can't totally depend on Dopplers in diabetic pregnancies. Normal Dopplers can sometimes mislead us to think that all is well. Timing of delivery in a woman with diabetes matters a lot. How do we time the delivery? When would it be okay to deliver the baby? Is 38 weeks a good time or 39? What if there are problems of prematurity since they are functionally immature? Will it lead to stillbirth while we are waiting for them to grow up? Will early delivery prevent all complications for the baby? Just delivering before all neonatal complications can be prevented. So according to FIGO guidelines, if the sugars are very well controlled, she's only on diet, then 40 weeks term is enough, but don't go beyond 40 weeks. Well-controlled GDM on metformin between 39 to 40 weeks. Well-controlled GDM on insulin, you will want to deliver between 38 and 39 weeks. But if she's poorly controlled, you will have to choose a time and deliver. Make sure the sugars are brought under control at the time of delivery. If estimated weight is 4 kgs or more, you can offer LSCS. In the absence of obstetric or diabetes complications, an elective cesarean section is best performed at 39 weeks rather than 38 weeks gestation. Wait for 39 completed weeks. If the sugars are well controlled and there is no other problem, please wait for 39 weeks. Intrapartum glucose targets, like if she goes into labor, what is the target, sugar target that we need to look at? 70 to 110, because high sugars can give rise to neonatal hyperglycemia. How do we monitor the sugars? It depends upon which phase of labor she is, latent or active phase, whether a woman has type 1, type 2 or GDM or glycemic control before labor. If it is latent phase and GDM on diet and metformin, you can check the sugars 6 hourly. If she's on insulin, 4 hourly. And then urinary ketones 6 hourly or as required. You may not have to do urinary ketones if the sugars are well controlled. In the active phase of labor, you check every 4 hours. And if she's on insulin, you will probably check every 2 hours. So management of glucose depends upon the type of diabetes and the glycemic control. In type 1 and type 2 diabetes, lower doses of insulin. In labor, when she's in active labor, you will have to reduce the dosage of insulin because, like I said, labor is exercise intensive. The sugars are mopped up by the skeletal muscles, and therefore the sugar values are much lower in labor. GDM on MNT only, no insulin is required. Uncontrolled GDM, of course, you will have to check the sugars and give. How do you give insulin during labor? If it is type 1 or type 2 diabetes, you give IV insulin infusion and 5%, one side IV insulin infusion and another side 5% DNS infusion. Or alternatively, you can give 5 units of regular or rapid acting insulin and 500 ml of 5% DNS. 5 units of regular insulin in 500 ml of 5% dextrosaline. You run it at the rate of 100 ml per hour. So you are essentially giving 1 unit of insulin every hour. If she is a GDM on lifestyle management, then there is no need to give insulin in labor. If you are inducing labor, it should be scheduled for early morning. Oral intake is allowed during cervical ripening and latent phase of labor. Rapid acting insulin is given based on glucose levels. When the woman goes into active labor, we follow the same thing that I just mentioned. Supposing you're planning an elective cesarean section for a woman who's on GDM on insulin, then you give normal saline is used for intravenous hydration before operative anesthesia to avoid administering a large glucose bolus because that can cause neonatal hypoglycemia. 5% dextrosaline infusion is given if glucose levels are less than 70. Then based on the sugar values, you give insulin. Post-operative glucose values, you follow the sugars. You check the sugars every 4th hourly and give insulin accordingly. Shoulder dystocia is extremely, this is the one which takes you to court. And amongst the diabetic pregnancies, documentation is very important if you do face shoulder dystocia. And this is the kind of documentation you will need to have. What was the time of delivery of the head, and what were the maneuvers, in what order did you follow, when was the baby delivered, which shoulder was anterior, whether it was the left shoulder or the right shoulder, and etc. You need to debrief the mother. And even if the mother is all nice now and doesn't complain anything and they're all very good, still keep the case sheet aside and be prepared for any litigation. Neonatal hypoglycemia is one complication that can happen in diabetic pregnancies. So all babies, all infants of diabetic mothers, you need to check the blood sugars. If it is less than 20 to 40 milligram within the first 24 hours, it's called hypoglycemia. Check it as soon as possible after birth. More than 30 minutes, 1 hour, 2 hours, 4 hours, 8 hours, and 12 hours. At any time abnormal clinical signs are observed, you need to check the sugar again. Now, why is it important? It might be totally asymptomatic, but neuronal cell injury, cerebral damage, long-term neurological sequelae can be there even in asymptomatic babies when the sugars are low. No single value below which or duration beyond which brain injury definitely occurs. Therefore, it is important to check the sugars and prevent and give prompt treatment. What about insulin after delivery? GDM patient on diet and exercise will not need insulin. Type 1 and type 2 insulin requirement will be reduced by 40%. During breastfeeding, the requirement of insulin can fall drastically, leading to hypoglycemia. So check the sugars and adjust the dosage of insulin. Breastfeeding is extremely important because it's a low-cost intervention for preventing type 2 diabetes in the mother. Mothers who breastfed for more than 3 months, the incidence of diabetes was only 42%, whereas the mothers who did not breastfeed or who did breastfeed but for less than 3 months, the incidence of diabetes in the next couple of years, it was almost 72.6%. Therefore, for her own sake and for the sake of the baby, breastfeeding is important. Postnatal visit, you will need to talk about diet, you need to talk about exercise. Make sure she continues to exercise, reduction of weight. She needs to come back to her pre-pregnancy weight, discuss contraception and the glucose test. Breastfeeding is important. Like I told you, the risk of developing diabetes is highest among these. When to call for follow-up between 6 weeks to 6 months. And now we have even have studies which say that before sending her home, you do a OGTT and send. And it correlates with the OGTT that is done at 6 weeks. But in any case, yearly thereafter, all women have to get glucose OGTT done every year. South Asians, the conversion rate is very high, almost 50%. By the time she comes for her next pregnancy, she'll be a frank diabetic. So it is very important that they are told very strictly to get their sugars checked and to continue their diet modifications and exercise subsequently in order to prevent diabetes. So what is the kind of test that is done? Here, it's not the DIPSI test, it's the WHO 75 grams OGTT. So you check the fasting plasma glucose. If it is more than 126, you have these values which will say what is diabetes, what is pre-diabetes, and what is normal. Preconception care. Supposing a diabetic woman comes to you in between pregnancies, you should make sure that sugar control is good. Don't let her get pregnant till the sugars are well controlled. If she is on oral anti-diabetic agents, it's ideal to switch over to insulin if pregnancy is planned. Control of hypertension, make sure she's not on ACE inhibitors, ARBs, because they can cause oligoamnios in the fetus. Statins to be stopped. Dilated retinal examination, fundoscopy has to be done, and the kidney function has to be checked out. So summary, target glucose levels in labor between 70 to 110. Women on lifestyle modification don't need insulin. Type 1 and type 2 need a smaller dose during labor. Insulin can be given as insulin infusion in labor or this one. Now, diabetic ketoacidosis is one complication that can happen during pregnancy. So I'm just going to say a few, this one. Unlike non-pregnant women, diabetic ketoacidosis can occur even with normal blood sugars. So that is the difference in pregnancy. Ketoacidosis can occur even with fairly lesser sugar values. It's presence with severe vomiting, women with severe vomiting, hyperemesis, infections, or insulin non-compliance, or those on beta mimetics, or those who are taking steroids for some other reason, or when there is insulin pump failure, then they can develop diabetic ketoacidosis. The treatment is fluid replacement, insulin therapy, and potassium replacement. Identifying and treating the cause for ketoacidosis, monitor the mother. Even though the fetal condition based on the CTG shows that there is some compromise in the fetus, the moment you correct all the metabolic problems in the mother, the fetal condition definitely improves. For the sake of the fetus, you don't rush and do a cesarean section. So decay during pregnancy is a life-threatening condition. It may be the first presentation of diabetes, rapid diagnosis, and rapid initiation of multidisciplinary team managed medicine. CTG changes usually correctable with maternal treatment. Delivery should be undertaken only after the mother is metabolically stable. Monitor sugars when giving steroids and avoid beta mimetics. I have a lot more slides, but I don't know. This is 7:41. Shall I stop here? What did I have? This is the long-term problems of diabetes in pregnancy.
I think we can take few questions. Karpagam, you are there?
I'll stop share.
Yeah, I think so. If there is anything else, any oral insulin, any recent advances, Sushila?
About insulin.
Oral insulin.
See, oral insulin will take some time to come through. It is, it would be ideal. It would be the only reason why oral insulin is not effective is because it gets metabolized in the digestive juices. There is a nasal spray of insulin, there's oral insulin, all this have been tried. But as of now, by the time it reaches the market from the research area, it will take quite some time. But it would be most welcome. I think a lot of companies are trying for this for many years now.
And
What about the HbA1c values, madam? For the benefit of the postgraduates, you can say.
Yeah, HbA1c values are useful to find out only in pre-gestational diabetes. Supposing at booking you find the sugars are high, you definitely need to get a HbA1c level done. This is because it will give us an idea of the sugar control in the previous 3 months or at the time when she became pregnant. Now, if the HbA1c values are high, anything more than 7 is associated with an increase in the incidence of congenital malformations. And by the time the HbA1c reaches 12%, the incidence is almost 25%. Now, having said that, if a woman comes to you with a HbA1c value of, say, 12.2% or 12.5% or even 11% for that matter, you do tell her about the complications of this high sugar values in pregnancy, that there is an increased incidence of congenital malformations, increased incidence of preeclampsia. First of all, there is a 40% chance of abortion when the HbA1c is high. That is nature's way of getting rid of abnormal babies, I would say. But then there is a 75% chance of normal pregnancies also, like, the fetuses being without congenital abnormalities. So we should not be offering termination of pregnancy just because the HbA1c is high, saying that this baby is likely to have congenital malformations. The way we counsel them is to tell them that there is a high incidence of congenital malformations. However, we have ways and methods of picking up all these structural abnormalities by our biochemical markers, by our ultrasound scans, which can pick up quite early in pregnancy, even as early as the 12th week of pregnancy. And if there is a problem, then we have a way out of it. If it is a congenital abnormality incompatible with life, we can always offer termination of pregnancy.
Two questions in the chat box.
Yeah, I will read out the question chat box. Dr. Radhika has asked for advising on plate method for diet. Is there a standard plate size? That's a very nice question.
It is an 8-inch plate.
Oh, that's it. That's
It's an
very
8-inch plate. You can have a big plate.
I
Ah.
know.
A small plate.
Quite often this is asked in the exams, madam, recently.
Yeah.
8 to 9 inches, yes.
And how frequently to monitor blood sugars during labor? That madam mentioned actually.
I think I've
Madam
said
mentioned.
that.
You mentioned that in their.
Actually, my question is, suppose if during pregnancy, what is the difference between the 4-point and 7-point? How often we should monitor the blood sugar?
I wanted to cover that. I'm
Ah.
sorry, I didn't cover that. See, if she is only, if the sugars are only mildly high, these days, we get glucometers at very, very reasonable rates, and there are companies which rent glucometers. Like I know of certain companies which they only need to buy the test strips, which works out cheaper than coming all the way to the hospital and getting the lab test done, etc. So self-monitoring of blood glucose has become very reasonable, and that is what I would advise all women. If they can have a mobile phone, I'm sure they can have a SMBG monitor. Now, if it is only a GDM managed on diet, then only 4-point sugars are enough, because these women are the one who have postprandial sugars which are high. So couple of times, you check the fasting blood sugars, and then more often than not, you check the postprandial. If the sugars are well under control, that is 4, fasting, post-breakfast, post-lunch, and post-dinner. You check it for 2-3 days. If they are well managed, then you can omit the fasting sugars. You can check only the postprandial sugars. And that also, any 2 sugars, 2 or 3 times a week should be more than enough.
Yes.
Now, which are those women who need the 7-point? These are women who have pre-gestational diabetes and who are on insulin. Even these women probably don't need all that 4 o'clock or 3 o'clock morning high sugars. That 3 o'clock sugars you check only in occasional women, where you find that the fasting blood sugar is high. You want to rule out a Dawn's phenomenon from a Somyogi phenomenon. Therefore, you will want, if the 3 a.m. blood sugars are high, then you know that you need to increase the night dose of insulin. If the 3 a.m. blood sugars are low, then you know that it is a reflex hyperglycemia, and therefore you will need to reduce the night dose of insulin. And only for that purpose, only where your fasting blood sugars are not coming under control, she will need to check the night. And that happens very rarely. Most of the women, they can get a fasting and postprandial blood sugars done, and that should be okay.
2 to 3 times a week is good.
Yeah, then either should, and they get to know they can coordinate
themselves.
with the food that they are taking, and they will know which food increases their. They themselves come and tell, oh, I had that. That is why my blood sugar is there.
Yeah.
They will modify their diet accordingly.
Yeah, they'll write it in bracket and come what they had. If they had sweets, they will write it in bracket. Okay. Next question. How to treat pregnant patient with only pre-meal blood sugar high? Yeah, that's what madam was telling. No pre-meal, it's like more like sugar, na.
Only
Just now, madam, you explained, no?
only pre-meal blood sugar being high happens only in pre-gestational diabetics, mostly in type 1 diabetics, or even type 2 uncontrolled type 2 diabetics. You check the pre-meal blood sugar. This will give you an idea of how much insulin you need to give for these women. So that, and you also check the post-meal. So I know if I give 4 units, the post-meal sugar is going to be so much. So I can modify the insulin dosage accordingly.
Madam, one question regarding HbA1c. I know we all know that HbA1c is only, especially mainly pre-gestational diabetes, where the adequate control is important for preventing congenital malformations. So, what is the role of HbA1c in anemic patients? Sometimes we see patients who have a high HbA1c, but the hemoglobin is low. So, how do we correlate that in terms of, somebody has a hemoglobin of 8 and HbA1c of 9 or 10, whatever?
If they are diabetic also.
Yeah, diabetic also and anemic also.
Then you don't give much importance to the HbA1c there.
Okay.
Because you brought out a very nice question. First of all, in our country, HbA1c as a test is not standardized.
Yes.
There is so we don't give too much importance to HbA1c. But having said that, in the first trimester, if the sugar values are high, you would want to get a HbA1c done. But if she is anemic, and also in pregnancy, you don't use it to monitor the blood sugars later on in pregnancy because there is hemodilution.
Correct.
There's more plasma than the red cells. So, and anemia. And many of the women do have hemoglobinopathies like thalassemia, which we don't have detected because it's not so important for us to pick up unless they are having gross anemia. So all these factors make HbA1c not a very practical test in our kind of a setup. It's not that HbA1c is out, but in our kind of setup, and especially during pregnancy, only in the first trimester, I would attach importance.
Yeah.
If I find that the sugars are not well controlled at all, then I know many endocrinologists do ask for HbA1c now and then.
Yeah, sometimes they ask for, I've seen people ask for effertosamin also. They say just initially in the beginning, if it's very high and the patient is very anemic, they say maybe you can say doing fructosamin and then seeing how the risk goes. That is one important point. Thank you, madam. Thank you very much for clarifying that. And most of our time, our pregnant women now, they have understood the importance of medical nutritional therapy, and many are following. My only concern that we see is, in pregnancy, they take care of them so well. They will listen to whatever we say, and postnatally, they will not do anything. We ask them to do a repeat DTT even when they are in mid-plan.
The only way you can emphasize in pregnancy, they will listen to you because they are very concerned about the baby. So
Baby.
Baby, they will do anything.
Correct.
And for their own sake, they may not make so much decision.
Correct.
The only way you can make sure that these women take a good care of themselves in the postnatal period is when you show them how many of them get transferred or become diabetic. Now, once they become diabetic, slowly they progress in the next few years. They progress to have nephropathy and retinopathy, etc. So we need to spend a little time to make them understand that it is not just for now. I wanted to talk about the long-term effects of gestational diabetes, but then, for want of time, and that for postgraduate students may not be very important for now. But then in clinical practice, I find when I check for infertility, when I get evaluation done, I find women diabetic.
Yeah. Yes, madam. Yes.
So in my gynae practice, when they, whatever reason they come to me for, I get a run because they won't come again for a checkup. So I get a RBS, I get an HbA1c, I get a CBC, and I get a TSH only done. There's 4 tests. CBC, RBS, HbA1c, and because the RBS might be normal, the HbA1c might be raised, and TSH value, because they won't come again for their testing.
Yeah. That's very true, madam. And
And
most
they
of
will always say, I don't have sugars. You don't have sugars because you've not checked for it.
it's, I would say, no, it's more of a, it's rather than acceptance, it's denial. எனக்கே வந்தது. Why did I get it? Why did I get it? So it's actually a lot of denial in the society itself about gestational diabetes, and then we have to really counsel them. And one thing that I have noticed in women who have this high fasting blood sugar is, I ask them to just have a early dinner, and ask them to go for a night walk. So most of them, when they go for a night walk, and sometimes they feel very hungry in the middle of the night. So I ask them to have something very without sugar before going to bed. So they don't fall hypoglycemic also in the middle of the night, and their fasting sugar is also getting controlled. So they the concern
Roasted peanuts, no?
correct.
That is a good snack item.
Yeah.
Or pottukadle with something. That is because roasted peanuts are rich in protein, and they are tasty too. Unlike other snacks, they are tasty. It is better than eating biscuits or cakes or any other pastry item. Biscuits are the most commonly used one. So they make, or they can have an apple. Apple also doesn't increase the sugars to that extent.
What about the postnatal checking of blood sugar, madam? When would you advocate? After 72 hours or?
See, if by the time
Post-delivery.
she is already on a normal diet, then you can do a OGTT in the postnatal period itself, like when she is still under your care. And then you can classify her as diabetic or impaired glucose tolerance or normal. But because many of them don't come back at 6 weeks.
Yes, that's why I asked that question.
Many of them. So if they are on a normal diet, or sometimes they come back 1 week later in the immediate postpartum visit, they do come. At that time, it is better to get it done. If they are on normal diet when they are in the hospital, then you could get it done even at that time. There are papers which say that it correlates well with the 6 weeks OGTT.
Yes. Thank you, madam.
Thank you.
We can close the thing. If there are any more...
No more questions in the chat box, madam.
We can finish the session.
Thank you. Thank you for a patient hearing.
No. It's all about GDM, and I wish there will be more talk on insulin management and all the questions. I thought one question is come, that chat box and something.
No. Thank you, Sam. Dr. Saratha has.
Okay.
Saratha has written thank you.
Yeah, I think you can do the official thanking for Sushila.
Yeah.
Thank you, Sushila, for accepting. Nice to hear. Maybe we'll be connecting in future also with you with more topics, not only GDM, but some other good topics also.
Thank you. Thank you.
I would like to propose a vote of thanks, madam. Thank you so much, Vijaya madam, Geeta Lakshmi madam, for giving us this opportunity every month. It's actually a very important learning point for all of us also. And we also start getting doubts what to do this. And even though we are seeing this in day-to-day clinical practice, thank you so much, Vijaya madam and Geeta Lakshmi madam, for the opportunity month after month. And Dr. Kiran madam, who is the chairperson of Foxy Medical Education Committee. So always indebted to her. In spite of her busy schedule, she had come all the way to log in and just bless us and wish us. And our sincere thanks to Sushila madam. It was very nice presentation. The initial pathophysiology, everything you went so nicely, step by step. And I was so impressed with your plates and your diet charts and your thing where how much your hands showing this much.
I have a long presentation on diet only.
Diet.
So one thing is, we should not limit the diet that I said for diabetic women, because we don't know who becomes GDM. This is the diet for all pregnant women.
Sure. Correct, madam. And I always feel, no, there is a lot of connection these days between, the gut and the brain health. Eat properly, eat sensibly, you will think sensibly and work sensibly. So there is a lot of connection, so much of insight into this brain gut health. So I always tell, we all eat for that one jan vaire that is going to take care of the entire system and including your brain. So better eat healthy and think healthy. So that is very, very important point. And their slide was very nice. And I was just seeing all the hands and the percentage. Thank you so much, madam. And as usual, Sahiti for the platform. Tremendous job she's doing in terms of, giving us this platform and sorting out all our technical things. And thank you so much for the patient listening. And it's a very great learning. And thank you, Vijay madam, because every month of I also look forward to the Aksharam session. However busy, wherever I am, actually,
Somebody has said that one topic on diet.
So you should
Diet,
we'll
yes.
have a
Okay.
session, ma'am, only
Yeah,
on diet. We'll have nice.
yeah,
Yeah.
yeah, yeah.
Yes, ma'am.
Because
One-
one last question, anyway, what are the fruits, madam? What are the fruits they can take?
They can take half a banana, or they can take a wedge of an apple or entire apple. Apple, surprisingly, the sugars don't spike up. Foods that they should
Wow.
strictly avoid are chiku, that is sapota, and then they can have guava. Guava is good, and
Guava
it
is
is
good.
rich in vitamin C. And they will say, can we have dry fruits? Yeah, they can have dry fruits, but the dry fruits are loaded with calories also. So badam is good, but you need to take 4 or 5 badam. If you eat a lot of badam, again, it increases the blood sugar. Raisins are not advocated because they increase the
Dates also, madam, dates.
so dates and raisins are not to be taken. And papaya, like somebody has written, papaya can be taken. Papaya is one beautiful fruit
Yeah.
in pregnancy. I don't know why somebody blamed it and said that it's
Artificial.
abortion. Even if you eat one whole papaya, you cannot abort. That is what I.
But pineapple, I don't think we should take. Pineapple is not good. Pomegranate is okay.
See, a wedge of a pineapple, a small piece of pineapple is okay.
But can't it-
Say, if you want to eat, can I have a wedge of a mango? Because it's a mango season. Mangoes
Jackfruit.
are likely to shoot up the sugars, especially because they are loaded with sugar. But if they are so much pushed, when pregnant women, the more you ask them not to eat, they will want to eat.
Yeah,
Also,
exactly.
you
The
can
craving
eat-
is there.
Yeah, you can eat, but then you need to cut down on subsequent calories.
What
Correct.
about sugar substitutes? You didn't tell anything.
Yeah, sugar substitutes, the ones that are available in the market, they are fairly safe. Saccharin was not good, but it is pulled out of market now anyway. What is that?
0 calories or something.
0 calories. No, the substitutes that are now available
Sugar free.
are fairly safe in pregnancy. This is called nominal aphasia. I don't get the name right at that. Anyway,
All of us will get it at some point in time.
That's that leaf, na? What is that? Yeah, the one that is available in the market is okay. But then they should learn to do without sugars. I mean,
Yes.
sugar substitute. Because I think, coffee or tea will taste better without sugar than with sugar. You'll start
Aspartame.
enjoying it.
Someone has written aspartame.
Lactulose.
Aspartame.
Lactulose is not used as a.
No, lactulose is not.
No, that you can't use.
It's used in laxative. Lactose is mainly used in laxatives.
Yeah.
Okay.
Thank you, madam. So,
But why use a sugar substitute? You can use without sugar.
I know.
But
Get
I mean,
used.
the idea is to make sure that you continue to follow this subsequently also. So why do you want to cheat your body saying that, it is sweet?
sometimes it's just a habit, madam, but you just get used to. So initially, even I was putting sugar in tea. Now I've stopped tea, sugar in tea. So now I've got used to tea without sugar. So it
Yeah.
comes by practice. You just do it for 3 to 4 days, and finally your brain also adapts to it.
Arul Kumaran was saying, Sushila, look at the crowd in front of the coffee. You people don't even have a sugar-free coffee stall.
Arul Kumarana.
சொன்னா அப்படிதான் இருந்தா I said it is very true. It's very true. Look at our conferences. Why can't we bring a change in the kind of food that we have in our conferences?
Yes,
Why
yes,
do we
madam.
need
Yes.
to load it with that kind of high calorie food? We can have
Yes.
more natural. I mean, see, if we want, we should lead by example.
Sure, sure.
Yes, Sushila. Thank you so
That's a nice idea, ma'am. That's a good idea.
much.
We should be the change that we wish to see, madam.
Yeah,
Thank
yeah.
you. Thank
We
you
should
so
be the
much.
change. Yeah.
And we'll
Right.
meet sometime.
Bye.
Bye.
Nice meeting
you
you
so much.
all. It was a pleasure being a part of this group.
Thank you.
It's
Thank
an
you.
honor also. Thank you very much.
Thank you so
Thank
much.
you, madam. Thank you so much.
Thank you, sir. Good night. Thank you, madam.
Thank you, Sagiti.
Thank you, Sahiti. Thank you, everyone.
Thank
Good
you,
night.
Sagiti.
Okay, Geeta.
Bye, Vijaya. Bye, Karpagam.
Bye, bye, bye.